Good morning, everyone. I was supposed to be the welcome, as you will have seen, for the programme, and I must apologise profusely for being late, but I actually flew back this morning from a weekend skiing. Anyone who knows me knows I'm an addict. So I was going to say welcome to the day, and clearly that's a bit late, but I think this is an excellent morning, and I actually, as the Director of Public Health, would like to thank Graham for putting that together and organising this, because I think he has pulled together an excellent day for all of us. As he said, I'm the relatively newly appointed Director of Public Health for the London Borough of Hackney and the City of London. I don't know whether you all know that as of last April, public health is no longer part of the NHS, it's part of the local government. So I am now employed by the London Borough of Hackney and also the City of London. But as the city only has 7,300 residents and tends to have cure rates of TB of 100%, as these small number things do, perhaps less relevant today. I do remember when I was in the department, a very bright young fast streamer coming up to me and saying how exciting it was that public health was going to move into local authorities, how new and innovative this was. And I'm afraid I showed my age by sighing and pointing out that public health had always been in the local authorities from its inception until 1974, at which point he looked at me as if I ought to step into my grave, which wasn't helpful. But I think it's useful to remember that when we first started to manage TB, that public health was part of the local authority and issues around housing and overcrowding were relevant then. As Graham has highlighted, TB has been with us for many years and its effects are very broad. And one of the things that all the cases that have recently been described in London as of last year, only 45% pulmonary. And I think it's very important to remember that because it is a great mimicker of other illnesses, as Graham has highlighted. By the time you've seen 5 consultants, perhaps TB ought to sort of cross your mind as part of the differential diagnosis. Graham also mentioned streptomycin going out of use. My uncle was a consultant in communicable diseases, and he was a consultant when streptomycin was first brought in for managing TB meningitis, and made a huge difference from if children survived the first 24 hours, they would make it, the children becoming very unwell for weeks and weeks, and then actually dying, which caused the nursing staff a lot of difficulties because they had then developed relationships with children and they died. The other issue, and this is about it isn't always pulmonary, when my parents' father was army, was stationed in Germany in the early 50s, they were not allowed to drink milk from the local cows because the herds were not TB tested. To her dying day, my mother could not look at a can of evaporated milk without shuddering. But it is not that far away in generational terms that we are looking at TB being very widespread. Graham has highlighted the issues around the world, and we're in a particularly diverse borough, but I actually did my public health training in Bradford. And there we used to have an immigration screening clinic for adults and children separately each week, in which we would test all people who had come into the borough, whether we had been notified or not. And that was a relatively stable ethnic minority population from the Mirpur part of Pakistan, who would always bring new incomers, basically because you also got registered with the GP and sundry other bits as well. But it was a comprehensive way of being able to tackle the incoming population, which is not done at the airports or other ports of entry. Heathrow has 24/7 medical cover, no other airport does. I think Graham has very excellently highlighted the development of 2 issues recently. One is a co-infection with HIV, and the other is multi-drug resistant TB. And while we still have a high rate of TB in London, actually we do not have the multi-drug resistant TB that we saw either in New York or are now seeing in Russia. And I think it is a huge compliment to the NHS, and particularly consultants like Graham and their departments and their teams, that we have managed not to, considering the international travel we have here, reflect those rates. Very helpfully, the Health Protection Agency, Public Health England, must remember all these new names, last week published the 2013 data for TB notifications. There were 3,020 notifications in London. In North East London, that was 905, and that's a rate of 49.9 per 100,000. Of the 5 old regional health authority areas or sectors in London, North West has the greatest rates, North East has the second greatest. Of those, Hackney had 87 cases last year. That rate is 34.5 per 100,000, and that is down from a rate of 48 per 100,000 in 2009. The Homerton had 89 cases, demonstrating it's got a wide catchment area. In fact, for Homerton and Hackney, you can often give the same figures because they have a very coterminous catchment area. Treatment completion. In Hackney was 88.6%. In Homerton, it was 89.8%, just short of 90%, but it had been over 90% the year before. And about between 3 and 4% of each of those figures, patients had died before they had completed their treatment. Of those who were HIV tested, 98.9% at the Homerton had been HIV tested. So that, I think, is a huge credit and is one of the highest rates in London. There is one other interesting thing, and Graham alluded to this, which is who are the clients that we are often dealing with, and it's those with other risk factors. Mental health, alcohol, prison, etc., etc. In London, 12% of those diagnosed with TB have other risk factors. In Hackney, it's 20%. For Homerton patients, it's 23.6%, and that is the second highest rate of a hospital in London. I have to tell you that of the borough rates, those with the greatest other factors, turned out to be Kensington and Chelsea, and I'm still trying to work out how that happened. And I think here prison is particularly relevant because certainly prior to the NHS being involved in prison health care, and that's about 15 years ago, there was no common communication or communication between different prisons about prisoners' health. And because of the pressure on prison places, I use my words carefully there, if you go to court for some sort of hearing, your chances of returning to the prison that you have just come from are extremely low. And not only might you not find yourself in a London prison, but you may find yourself 200 miles away. And that is the everyday experience of prison. Not only does that affect you, the fact you have to keep packing up, the fact that your relatives can no longer come to see you, but if you had had an outpatient appointment, I'll ignore that, if you had had an outpatient appointment at a local hospital, you won't be making it. Now, perhaps this then won't be made again in the new, or you will go to the back of the waiting time in your new prison, etc. So it is very relevant that those who have been in prison are at very high risk of not only getting their TB, but having difficulty in managing it, and certainly the risk of getting multi-drug resistant TB. And I think, though that we don't have a prison in the local catchment area, I suspect certainly a number of our clients have had some experience in prison health in the past. So I apologise again for my slightly late arrival. I wish you all the best for the day. I'm afraid I won't be staying for the radiology bits and beyond that, on the grounds of I'm not sure I entirely understand anymore, so thank you.